Good morning, and thank you for the invitation today. When I learned I had 10 minutes to say something interesting to you, I felt I was at a distinct advantage over some of my co-panelists because coming from New York, I can speak very quickly. I can get an hour's worth of content into about 10 minutes. I'm also from Queens County, New York, which is the most culturally diverse county in the country. So it's no mistake or accident that my comments today focus on this topic. A lot of the comments today have been focused on patients that pursue PAD. I'm going to talk a little bit about the patients or the potential patients that don't pursue PAD because I think there's some attention that needs to be directed towards them as well. So to answer the question, is there relevance for PAD when we think about ethnocultural disparities in palliative care? I'll answer the question right up front. I don't know. But I think there are important questions to ask about that. So what we do know is that PAD disproportionately is a concern of well-educated whites. The states where it first took root, predominantly white relative to the rest of the country, better educated. And I think these data alone should stimulate some questions. We know in healthcare generally and also in palliative medicine, there are disparities and distrust in the health system. These have roots that are well-founded. Scientific racism over the last couple of centuries, racism in research, it's well-established. We don't need to go through examples. We're all familiar with them. Racially based discriminatory practices, both explicit and inexplicit, and there's a recent article in JAMA 2015 that I can direct your attention to. And we know that there are reverberations of this that manifest in organ donation activities. Some members of our community are concerned about going to the hospital for fear of having organs taken from them. When HIV was epidemic, concerns about conspiracy theories in some communities that it was developed to eliminate members of our community. And there's some implications for palliative care, and the question is, are there implications for PAD as well? In palliative care, the literature suggests that African Americans versus whites have greater preference for life-sustaining therapies for similar prognoses, or even regardless of prognoses. African Americans tend to be less likely to assign a healthcare proxy or complete a living will out of concerns that these legal documents will be used against them in some fashion. There's a lower utilization of the hospice benefit. There's a greater rate of revocation of hospice benefit once they are on hospice care. There's less knowledge about palliative care. African Americans are less likely to embrace goals of palliative care versus whites due to spiritual and religious beliefs. I'll talk about that in a moment. African Americans tend to have poorer pain control. Important study coming out of Mount Sinai a couple of years ago, finding that people of color have less access to pain medications because the pharmacies in their communities tend to stock those medications less often. So what are the drivers of these disparities? Is it mistrust based on all the elements that I just mentioned? Is it spirituality and religious beliefs that may differ? The literature is actually a little bit conflictual. There is literature supporting both of those bases for drivers of disparity. Also confounding is health literacy versus race. We're not so sure. There seems to be evidence supporting health literacy as an independent variable. There are black-white disparities in effective communication for hospitalized patients and in care plans when controlled for preferences. So how African Americans are engaged in the hospital in discussions about care planning and how those care plans or those preferences are enacted, there are some disparities and there's some references there to support that. And there are disparities between palliative team and hospice members and minority populations. Going back to the organ donation issue, some studies find that African Americans are just as interested as whites as donating organs. It's just that the procurement teams tend to be disproportionately white, and there's a bias that may be set up that is maybe bidirectional. So it's very complex, and I don't want to overly simplify these issues, but just raise these issues as things that we need to consider as we go forward and think about PAD. When we look at the literature on PAD and minority concerns specifically, the literature is fairly thin. Some data suggests that African Americans higher distrust of medicine may not influence attitude towards euthanasia or assisted suicide. Spiritual concerns may be more relevant as a factor. And other data suggest that mistrust is a driving force. So we don't have clarity. And some of that clarity or lack of clarity may be related to the quality of the survey data, which if you read the surveys, if you look at the surveys closely for methodology and bias in the formatting of the surveys, there's a lot to be desired. So there are purported arguments against PAD back in the day of Vaco versus Quill. Dr. Quill's here. The New York State Task Force, Life and the Law, they posited the argument that we'd have to protect vulnerable populations from coerced assisted death. I don't think that's really a strong argument, but there are other arguments to consider. And I think the argument to consider more strongly is if PAD is available, will that create a backlash against among populations that already have mistrust in the health system? That now if they come to the hospital, is there yet another tool that the hospital or the institution has against them, just like concerns about coming to the hospital and being undertreated in order to get organs or to be infected with HIV? Does this create another basis for inflaming mistrust in minority communities? We don't know. There's no data. It's speculative, but it's a question I think that we need to ask as we go forward. So is PAD health policy or social policy? It's a relatively new medical paradigm, particularly in the US. What is the imperative? To serve health goals of needy populations, to attend to sociocultural trends towards control over self? Are there other phenomena that are driving the social trend towards greater interest in PAD? So we think about PAD in the context of social policy. Social policies are concerned with a right ordering of networks of relationships between men and women who live together in societies, or with the principles which should govern the activities of individuals and groups so far as they affect the lives and interests of other people. And to the extent that we can think about PAD in the context of social policy, we need to also focus not just on the populations that are accessing or pursuing PAD, but all of the populations that might be affected by the availability of PAD in our communities. Health policy has the intent to reduce morbidity and mortality. There should be data that substantiate a program will reduce morbidity or mortality, that the burdens of the program must be identified and minimized. The program must be implemented fairly and must minimize pre-existing social injustices. Fair procedures must be used to determine which burdens are acceptable to a community. And I think it's important to think about PAD in light of a health policy framework. And again, this just schematizes things that we should be considering as we understand that PAD is part of the landscape. So what we don't know, or we don't know well, we don't know current attitudes of minority communities towards PAD, the factors underlying these attitudes, the likely influences and the actual influences of PAD, if any, on trust in physicians, healthcare workers, the hospital system, healthcare or health system utilization, access, end-of-life care planning and preferences, quality of dying, hospice use, and organ donation activities. We just don't have good information on all of these things, but these are important questions to ask. So in summary, and I told you I would speak quickly and get it all in summary, PAD is disproportionately a concern of well-educated white demographic, minority populations' differences in spiritual and religious orientation, the unique American socio-historical memory, and other factors may be relevant in terms of unintended consequences of legalized PAD. To promote evidence-based health and social policy, these considerations should be judiciously studied in jurisdictions in which PAD is permitted. And California is going to be a very important experiment for us because it's a demographically diverse state relative to Oregon and Washington. And I encourage my colleagues from the other coast to think about these questions. Thank you.